Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS learning that you can fit into your busy life. The voice you're listening to right now is me, Rhiannon Ashman, Deputy Editor of MIMS Learning. And if you're a regular listener to this podcast, here's another familiar voice.
Hello, it's me, Pat Anderson.
Hi, Pat. So, Pat, how do you feel about listening back to your own voice on this podcast?
Well, if you'd asked me that a couple of decades ago, I would have minded and been really embarrassed. But over the years, partly because I'm a singer in a band as well, I've just kind of lost the embarrassment about hearing myself, and it's no longer a big deal.
That's good, because for me, listening to my own voice on a recording is a humbling experience. And I've noticed I've got a vocal tic that I hear on recordings of myself, but I'm not going to tell you what it is, because otherwise that's all you're going to hear for the rest of this episode.
Intriguing.
But being able to project our voices, to be heard and understood, is something that we all take for granted, unless or until something disrupts this. And that's what we're going to be considering on today's episode. So can we have a quick anatomy refresher, Pat?
Sure. So the voice box or larynx is a hollow tube made of muscle, ligaments and cartilage just above the trachea. The vocal cords are also known as vocal folds, and of course their vibrations are responsible for sound production. The glottis, which is the space between the vocal folds, opens and closes during breathing and sound production. When healthy, the larynx also fulfills the complex roles of respiration, airway protection, which we'll come back to, and swallowing. If vocal cords become swollen or inflamed, develop growths, or can't move as they should, they can't work properly, and any of these might cause a voice disorder.
Thanks, Pat. And voice disorders are a range of conditions that affect the larynx, and they can cause changes to the voice called dysphonia or loss of voice called aphonia. And these changes can affect the way the voice sounds, for example, making it sound hoarse, croaky, strained, breathy, or weak. Now, vocal disorders can cause difficulties in day-to-day life. For example, it may be difficult for people to be heard by other people or may affect their work, school, or hobbies. And voice disorders can also cause frustration, low mood, or isolation in some cases. And in a learning module on this topic, Dr. Sunita Kochar explains that hoarseness, or dysphonia, may be described as an abnormal vocal quality, which may cause a weak or strained voice, as I've said, or a voice with a change in pitch. And she notes a study from 2010 suggesting that hoarseness has a prevalence of 6% in the general population and 11% in those who use their voices professionally.
Yeah, and the profession that springs to mind there for me is teachers. They're prone to losing their voice as they have to be using it all day, and it's really debilitating for them if they lose that capacity.
Absolutely. I immediately thought of singers, actually, like you, Pat. And although the figure quoted in that module is 11%, I did come across some research from 2017 which found that overall prevalence of self-reported dysphonia in singers was 46%.
That is high.
It is, actually. And a quick internet search of singers who've experienced some kind of vocal injury includes Julie Andrews, Michael Bublé, Whitney Houston, and of course you might remember that Adele and Celine Dion have both been in the news fairly recently because of their struggles with vocal disorders. And in many cases, singers can develop vocal cord nodules, which are benign growths on the vocal cords. Now, my sister-in-law is actually an opera singer, and I was intrigued as to whether opera singers have higher rates of voice disorders than other singers because of the intensity of that style, but I can't find any convincing evidence on that.
I think there's an interesting learning point in any case about the importance of occupation and even relevant hobbies in the risk of vocal overuse.
Yeah, and even for those of us who can't hold a note, hoarse voice is a common symptom that accompanies upper respiratory tract infection. And in this case, the other symptoms or the history would likely point to the cause. So, for example, hoarse voice presenting with rhinitis and sinusitis may suggest an upper respiratory infection. And in this case, the hoarseness would usually be self-limiting.
Yes, laryngitis as a result of infection or irritation of the voice box is the most common cause, and as you say, it will usually resolve on its own. But the NHS advises patients to see their GP if their hoarse voice persists for more than 3 weeks, as this may be a red flag. Other red flags in patients with hoarseness include difficulty swallowing or dysphagia, or painful swallowing, hemoptysis, smoking history, and weight loss.
And given that we're talking about red flags, let's first off consider malignancy, since that will probably be top of your list to rule out. So in a learning module on the NICE guidance on neurological conditions, the author says that NICE advises an urgent referral for suspected head and neck cancer should be made for people aged 45 years and over with persistent unexplained hoarseness or an unexplained neck lump to rule out laryngeal cancer. And in the red flags learning module that we talked about earlier, Dr. Kochar says that a hoarse voice may be the presenting complaint of squamous cell carcinoma of the larynx. Now, this is a rare condition occurring in 5 in 100,000 men and in 1 in 100,000 women, but should be considered particularly if there are risk factors such as increasing age, smoking, excessive alcohol intake, or gastroesophageal reflux disease. She also says that heavy smoking and excessive alcohol are synergistic risk factors, and human papillomavirus infection, typically subtypes 16 and 18, may also be a risk factor. Now, malignancy or laryngeal papillomatosis may cause symptoms of airway obstruction, so be alert to this as well. The presence of lymphadenopathy may, of course, be suggestive of infection or malignancy.
Yes, and interestingly, lung cancer with mediastinal spread may also cause injury to the recurrent laryngeal nerve, resulting in hoarseness, and there are iatrogenic causes. For example, laryngeal nerve injury might occur as a result of thyroid or cardiothoracic surgery, resulting in unilateral vocal cord paralysis, while direct trauma might occur, for example, from endotracheal intubation, which can also cause hoarseness.
Neurological causes of a hoarse voice include multiple sclerosis and Parkinson's disease. Indeed, dysphonia can be a presenting symptom in Parkinson's disease, although there may also be other symptoms, of course, that point to this diagnosis. Systemic causes of a hoarse voice include hypothyroidism, and we have a webinar available to watch on demand on the diagnosis and treatment of hypothyroidism, which we can link to in the show notes if you're interested. And rheumatoid arthritis also may affect the cricoarytenoid joints, which are 2 small joints at the back of the larynx that are involved in movement of the vocal cords during speech. And less commonly, sarcoidosis and amyloidosis may also cause hoarseness.
Fascinating. So what features of the history should GPs focus on?
Well, according to Dr. Kochar, it's important to find out how the patient feels their voice has changed, as well as getting some information about the onset, duration, and any fluctuation in symptoms. So, for example, hoarseness that worsens as the day progresses may be suggestive of vocal fatigue associated with myasthenia gravis, whereas hoarseness that is worse at the beginning of the day may be suggestive of laryngopharyngeal reflux, or silent reflux, which is distinct from gastroesophageal reflux. A tremorous voice may occur in Parkinson's disease, and a breathy voice may indicate vocal cord paralysis. Progressive symptoms may suggest more serious pathology.
Apparently, you may also want to find out if there's been exposure to allergens or irritants, because if there's any history of asthma, as well as inhaled corticosteroid use, this can be related to chronic hoarse voice. And as touched on before, alcohol intake and smoking status should be assessed. Psychological stress may also be relevant. And in terms of specific questions in the history, consider asking about cough, dysphagia, heartburn, hemoptysis, odynophagia, otalgia, weight loss, rhinorrhea, wheezing, and eye watering.
And what are the options for management, Pat?
Well, depending on the suspected etiology, in the first instance, vocal hygiene can be recommended. This includes advising patients to avoid exposure to irritants and cigarette smoke. Vocal overuse, as well as repetitive throat clearing and coughing, should be discouraged. Avoiding dehydration, reducing caffeine intake, voice rest, and steam inhalation may be helpful. Advising patients about reducing alcohol consumption and smoking cessation may be relevant. Other options include a trial of proton pump inhibitor therapy, altering inhaled medication if relevant, or optimizing therapy in those conditions known to cause hoarse voice. If hoarseness is persistent with no obvious cause and no symptomatic improvement, direct or indirect laryngoscopy is indicated. The module on NICE guidelines on neurological conditions also highlights that if structural abnormality and malignancy has been excluded by ENT, but the patient has persistent dysphonia, you should consider referring to neurology for treatment of laryngeal dystonia.
You mentioned in your anatomy recap, Pat, that the larynx is also involved in breathing and airway protection. So given the interconnectedness of all of these functions with sound and voice production, I think it's important to mention a learning module that we have on inducible laryngeal obstruction, or ILO. Now, this was previously known as vocal cord dysfunction or paradoxical vocal cord movement, and it's defined as an inappropriate and unexpected narrowing of the larynx during inspiration, which can lead to breathing difficulties. So while ILO is thought to be uncommon, its true incidence is unknown because the diagnosis may often be missed. However, research does suggest that it frequently coexists with asthma, or it may even be misdiagnosed as asthma. And you mentioned the airway protection function of the larynx. The mechanism of this is known as the laryngeal adductor reflex, and it leads to a brief closure of the vocal cords. The activation of this system can be triggered by many of the irritants that GPs would be advising patients to avoid as part of the vocal hygiene that you mentioned earlier as well. And that is cigarette or vape smoke, cleaning products and perfumes. And the authors of this learning module say that ILO may be a consequence of hyperexcitability of these reflex pathways, resulting in inappropriate triggering of the laryngeal adductor reflex by normal exposure to mechanical or chemical stimuli. And as we've just spoken about, voice changes are one symptom of disruption to normal laryngeal function, but airways symptoms such as breathlessness and dry or tickly cough can also indicate a laryngeal problem. There's a nice diagram in this learning module showing how symptoms of ILO, dysphagia, chronic cough and hoarse voice can overlap.
So we've discussed the change in the sound of a person's voice, that is dysphonia, but what are the other possible presentations that can affect someone's speech?
Well, in terms of speech disorders, as distinct from voice disorders, there are a few different presentations, including dysphasia, which refers to a difficulty in producing and understanding language, dysarthria, which involves difficulty speaking because of problems with the muscles of the mouth or face, and mutism, which we probably all know involves an inability or unwillingness to speak. And I imagine this can be a really worrying symptom for the patient and for those around them, and it's probably quite tricky for GPs to determine the cause.
Yes, in a red flag module on the topic of speech disturbance, Dr. Pipin Singh says that although GPs may not always be able to make a definitive diagnosis when someone presents with speech disturbance, there may be features in the history that do allow a definitive diagnosis, or at least help GPs to identify where to navigate the patient to and the degree of urgency.
So what are some of the red flags that might warrant urgent action?
Well, I'm going to list the red flags. There are quite a few, but they are significant. So, first of all, we have progressive memory loss, severe headaches, symptoms of stroke or TIA, such as weakness of the arm, face or leg, new onset vertigo or balance problems, recent head injury, decline in mobility or change in gait, significant unintentional weight loss, fever, visual changes such as diplopia, difficulty swallowing, change in handwriting, persistent unexplained twitching, mood disturbance or behaviour change, new medications such as antipsychotics, new neck lumps, and last but not least, a previous history of malignancy. The change in handwriting is an interesting one. The module we have that reviews the NICE guidelines on neurological conditions says that handwriting may be something that's unlikely to be asked about, but the NICE guideline notes that sudden handwriting difficulty may raise the possibility of stroke. So where adults are having difficulty with handwriting and a musculoskeletal cause is not obvious, consider the following. Does the issue lie with generating language rather than hand function? And if so, you need to refer for neurological assessment. And if the writing is small and slow, consider Parkinson's disease.
So in the red flags module on speech disturbance, Dr. Singh notes that patients may not be able to describe their symptoms, so you may need to gather a collateral history if that's appropriate. And as well as eliciting any red flags, as you've just described, Pat, it's likely that smoking and alcohol history will be relevant either due to there being a direct cause for the speech disruption or these being associated risk factors for another cause. And he says that knowledge of a patient's driving status may also be relevant, so that's useful to note. And how about primary care examination?
Examination might include a neurological examination, including cranial nerves, a gait assessment, cerebellar assessment, assessing for stigmata of chronic liver disease, mental state examination, throat and neck examination, including palpation of local nodes. And the module also lists some suitable primary care investigations, such as CT head, MRI head, and or cognitive tests.
And there are a number of possible causes, some of which overlap with the potential causes of hoarse voice that we've already discussed. So, for example, neurological conditions such as Parkinson's disease. And in that learning module on the NICE guidelines on neurological conditions, the author says that progressive slurring or disrupted speech requires referral to neurology to exclude neuromuscular disease. But bear in mind, if there's also breathlessness on lying flat, you should refer immediately. Or if there is swallowing impairment, then refer urgently. Sudden onset speech or language disturbance may raise concerns about an acute vascular event. Traumatic brain injury may also affect speech, and stroke is obviously a key concern if there's speech disruption. Indeed, this is the S in the fast mnemonic. which also includes face and arm weakness. And the Stroke Association says, can the person speak clearly and understand what you say? Is their speech slurred? And they add that difficulty finding words or speaking in clear sentences is another sign of stroke. And any one of these signs of stroke is an emergency and would require urgent evaluation in casualty.
Okay, and how about dementia?
Yeah, absolutely. The red flags module on speech disturbance also reminds us that dementia may lead to speech changes. And if you suspect this diagnosis, a referral to memory services would be warranted. Interestingly, the Alzheimer's Society says that in some types of dementia, such as frontotemporal dementia, a person may start to have problems with language much earlier than they would in other types of dementia, and it may even be likely to be one of the first symptoms that's noticed. So as well as struggling to find the right words, people with dementia may use words that have no meaning or that are jumbled up in the wrong order. And they may also revert to speaking their first language. So, for example, if they learned English as a second language, they may forget how to speak it. And if the change in speech is sudden, you may consider delirium, which we have a number of learning modules on, which we'll link to also in the show notes. So what are the other possible medical causes of speech disturbance, Pat?
Well, similarly to hoarse voice, speech disturbance can indicate thyroid problems, and you should refer to endocrinology if thyrotoxicosis or significant hypothyroidism is identified. Other possible causes include sepsis, certain drugs such as opiates, anticholinergics and antipsychotics, alcohol excess or recreational drug use, in which case alcohol services may be needed, or metastatic disease.
And not forgetting that speech disturbance may be a feature of neurodevelopmental conditions such as autism. In our learning module on autism, the author says that there may be unusual speech patterns, such as repeating phrases or literal or unusual use of language. And speech disturbance may also occur as a result of psychological conditions such as depression and anxiety, as well as serious mental illness. So in a learning module on schizophrenia, the author mentions how disorganised speech or thinking is a possible symptom of the condition, and that may include irrelevant speech and invented words, as well as meaningless repetition of words or phrases. So what have we learned today? First, we noted that hoarseness has a prevalence of 6% in the general population and 11%, if not more, in those who use their voices professionally. Now, I found it interesting to reflect on the impact that people's occupations or hobbies can have on their voices. And this is something worth bearing in mind when taking a history and considering the impact that the voice disturbance might have on an individual. Second, in a patient with hoarse voice, features that can give a clue to the diagnosis include progression of symptoms. So hoarseness that worsens during the course of the day may indicate vocal fatigue associated with myasthenia gravis, whereas hoarseness that's worse at the beginning of the day may suggest silent reflux. A tremorous voice may occur in Parkinson's disease, and a breathy voice may indicate vocal cord paralysis. A third, as we know that speech disturbance is common as dementia progresses, but we were reminded that some types of dementia, such as frontotemporal dementia, may present even with problems with language, or the language problems might develop much earlier than they would in other types of dementia. And I'm going to throw in another quick reminder of some of the other medical conditions that can cause speech disturbance, as well as neurological conditions such as Parkinson's disease and stroke. Speech disturbance can indicate thyroid problems, sepsis, alcohol or drug use, or be caused by certain medications, including opiates and anticholinergics. So thank you very much for joining me for this discussion today, Pat.
Thank you.
I hope we've all enjoyed listening to our voices for the last 15 minutes or so.
Yep, absolutely.
And don't forget that you can claim CPD credits for listening to this podcast. So be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. So thank you very much for listening. We've been the MIMS Learning editorial team, and this episode was produced by Jude Owen. Next week, our colleague Dawn Liz Powell will be talking to GP Professor Carolyn Chew Graham about supporting people with learning disabilities in primary care. So hope to see you then. Thanks.